Good afternoon, everyone. I'm Stanley Brown. I'm the Dean of the Dalla School of Public Health. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Welcome today to the second annual lecture of the Vohra Miller Lectures in Critical Public Health Issues, in collaboration with the Institute for Pandemics at the Dalla School of Public Health. The Institute, along with its lead donors, the Vohra Miller Foundation, sponsors a lecture series that will feature, amongst others, prominent scholars, policymakers, and advocates engaged in the science of pandemic-related health inequities, other critical public health issues, and in the translation of that science, both to our community here at the University of Toronto and more broadly. The Institute of Pandemics was formed in order to tackle some of the most pressing issues associated with the COVID-19 pandemic and make sure that we understand how to prevent and respond better and recover better from future pandemics. This afternoon's discussion, Health Equity and Transformation Through Community Advocacy, will feature a panel of excellent scholars and health system experts and their varied perspectives as they examine health equity in relationship to community advocacy, engagement, and community level work, particularly in this context of a pandemic. A dialogue on issues such as impactful community-focused work with Canada's Indigenous and Black communities and the inequities in healthcare, particularly those seen during the COVID-19 pandemic, will be a key part of this discussion. And we've become increasingly aware of the need to address inequities in health and healthcare. They've been with us. We're aware of the need to address them more and more these days, as well as the role that communities can play as leaders and advocates. Today's lecture and panel discussion will be moderated by Professor Arjumand Siddiqi, one of our faculty here and a Canada Research Chair in Population Health Equity. My thanks to Professor Siddiqi and to all the speakers today for sharing their perspectives and for continuing to support and participate in discussions such as these. And my thanks as well for all the work that you've been doing during the pandemic. Your participation and contribution will help to enrich information and will help to make sure it gets out to everyone. Now, without further delay, let me turn things over to Professor Siddiqi. Professor Siddiqi.
Thanks so much, Dean Brown. It's such a pleasure to be here with all of you. Before I make some comments and introduce the panelists, I think we have a short video from the Pandemic Institute that will play now. Thanks very much.
COVID-19 has impacted people in a very inequitable way. Racialized and marginalized people have been hit hardest. Our foundation, the Vohra Miller Family Foundation, has partnered with the Dalla School of Public Health to launch the Institute for Pandemics. The Institute for Pandemics takes a holistic view of the pandemic, focusing not just on the current crisis, but also on resilience and recovery using health equity lens as a key driver. The greatest strength of the Institute is the intersectionality that is built from the ground up. We will be liaising with epidemiologists, infectious diseases, health systems, policy, economics, bioethics, and many more. The road to recovery is going to be long and hard, but it must be done in an equitable way. We absolutely cannot leave anyone behind.
Thanks so much to Sabina Vohra Miller and the Vohra Miller Foundation for being so supportive of the Pandemic Institute of Dalla in general. We really appreciate your commitment to public health and to health equity in particular. I'm thrilled to be here today. It's such a nice event to gather and to be able to think about issues that I think are part of all of our professional and personal lives. We are really fortunate to be able to gather individuals who work in communities and societies on issues of equity, and particularly have been doing so during the pandemic. In the first Vohra Miller lecture last year, we focused on the large sort of structural context for equity during the COVID-19 pandemic. And we had Dr. Nancy Krieger come from Harvard via Zoom to chat with us about the research that she's developed on this topic and what some of the sort of big questions are that we are trying to tackle in terms of the structural context. And we also had two panelists who engaged with Dr. Krieger and with the audience, Camille Orridge, who is a health policy expert, who has been a longtime professor at Dalla School of Public Health and also has played major administrative roles and roles in the community and is sort of an indispensable source of knowledge and action in Toronto and in Ontario for health equity, as well as Joe Cressy, who is a city council person who very early in the pandemic was very interested in understanding what communities were saying about health equity during the pandemic, about data collection and so on. And so we had a sort of policy-oriented discussion, a structurally oriented discussion about health equity from people who were sort of operating at those levels. And this year, we felt that it would be really a nice complement to have a discussion that's really rooted in the community, where people who you'll hear from are working mostly at the community level, though from different perspectives. You will hear from three very illuminating and illustrious individuals who are doing work during the COVID-19 pandemic on health equity, particularly as it relates to Black people in Canada. Our keynote speaker today is Dr. Omishre Dryden, who is it's really hard to put this stuff into words. It doesn't quite do it justice, but she's really been a force in bringing together scholarship, communities, and activism in ways that have been really powerful. Dr. Dryden is the James R. Johnston Chair in Black Canadian Studies at the Faculty of Medicine and also an associate professor in the Department of Community Health and Epidemiology at Dalhousie. Tomorrow, I believe you will be getting emails with the longer bios of these individuals. I can't do them justice, but B, I want to save the time for them to chat with you. And at the same time, I want you to understand how amazing these folks are and what they've done. The panelists that will be engaging with Dr. Dryden are Cody Bernard, who's the Director of Equity, Inclusion, Diversity, and Anti-Racism for Ontario Health, and Dr. Suzanne Souche, who's primary care physician at St. Michael's Hospital, Unity Health, and the Inner City Health Associates. And she's the lead physician of Namirez and Odeman and Kalanti clinics. These are people who are working at the community level, but as I mentioned, from different perspectives. So Dr. Souche is a physician, and she's been engaging on the front line, doing clinical work as well as sort of community engagement work during the pandemic. Mr. Bernard, Cody Bernard, is working with the government, with Ontario Health, and engaging with communities and sort of being a liaison between communities and sort of the Ontario health infrastructure. And as I mentioned, Dr. Dryden is working on research, but also sort of community building as a scholar in Nova Scotia. So I won't say much else except that I'm really thrilled to have everyone here. I say many, many thanks to the support staff, Erica Thomas and her team, for everything they've done to make today happen. And I'm really excited for the discussion ahead. The order will be that Dr. Dryden will speak, and then Mr. Bernard and Dr. Souche will respond. We'll then have a conversation with the panelists, and then that'll transition to opening up for questions from the audience. And so if you have questions, I urge you to pose them in the Q&A function of Zoom, and we will try to get to as many of your questions as we can later in this session. So without further ado, let me hand it over to Dr. Dryden. Thank you so much.
Thank you, Arjumand, for the lovely invitation and the lovely introduction. It remains a great pleasure to be in community with you, and I'm thrilled and looking forward to the conversation with Cody Bernard and Dr. Suzanne Souche. So I know we've been doing this for 18 months or so, but I'm sharing my screen. It still causes me some anxiety, so just send me some extra woo. So, yes, my name is Dr. Omishre Dryden. I live, work, and study in Chibuktuk, the traditional unceded territory of the Maliseet, whose ancestors, along with the whose ancestors, along with Mi'kmaq and Passamaquoddy nations, signed peace and friendship treaties with the British Crown in the 1700s. Yet we must not forget, I was hoping that wouldn't happen. Yes, we must not forget that these treaties were signed roughly 140 years before the end of slavery in this region now called Canada. Halifax was imposed upon Jabuktuk in 1749, and it was enslaved African people who were used to dig out the roads and build the city, including much of the citadel. On the southern shore of the Bedford Basin, Mi'kmaq folks shared land with Black people, and this allowed Africville to be founded in the mid-1800s. I honor Indigenous and Black people who continue to be here, who continue to fight against genocide, anti-Indigenous and anti-Black racism, and the afterlife of slavery. Every child matters. So I've been asked to speak for about 20 minutes, and we'll focus on health equity, disparities, and radical community commitments to our well-being. Ultimately, I'm adding my voice to many brilliant people in our community who have been leading and engaged in this work and providing us with insights while also inciting change. But I'm going to apologize because I'm hoping that animation was just for this first slide. So let's hope it doesn't advance again. So I'm going to speak a bit about the James R. Johnston Chair. The James R. Johnston Chair is a significant senior academic post in Canada based in Halifax to honor not only the life of Mr. Johnston pictured here, but also to recognize and honor the unique historical presence of African Nova Scotian, Black Scotian people and communities. Mr. James Robinson Johnston, an African Nova Scotian man, is notable for a number of documented firsts attributed to his life. He was the first African Nova Scotian person to earn a Dalhousie degree in 1896, and the first African Nova Scotian person to graduate from university, and the first Black lawyer to practice law in Nova Scotia. But more than that, he is remembered today for his commitment to seeking justice for African Nova Scotian communities. He died tragically in 1915, just days before his 39th birthday. In 1991, nearly a century after Mr. Johnston studied at Dalhousie, and in honor of his many accomplishments, the university established the James R. Johnston Chair in Black Canadian Studies, at the time, the only endowed Black Studies chair at a Canadian university. The chair is also unique in that each 6-year appointment occurs in a different faculty and academic unit. In 2019, my appointment, the James R. Johnston Chair, moved into the Faculty of Medicine for the first time. Previously, the chair has been located in the Faculty of Law, Health Professions, and Arts and Social Sciences. This academic year, 2021, marks the 30th anniversary of the establishment of the Johnston Endowment and the 25th anniversary of the appointment of the first chair, Dr. Esmeralda Thornhill, in the Faculty of Law. So the chair is rooted in Black studies. And as we know, Black studies is rooted in radical political and activist movements. And as we know, Nova Scotia has vibrant and politically active African Nova Scotian, Black Scotian, and Indigenous Black communities. The situation, we're aware that, Black life in Canada, including African Nova Scotians, is an intricate and complicated as it is diverse. Therefore, strong connections within African Nova Scotian communities, for me as somebody who moved from Toronto to Halifax, is a cornerstone of the chair, but also the way that this work happens, and it's vital. And this, I and others argue, is actually the cornerstone of Black studies, working in community, being in community, working collaboratively with community. In order to document and affect the complicated relations of Blackness, one must be in relation with the articulations, gestures, appearances, and conditions of Black people. And here I draw from the work of Ronaldo Walcott's editorial in the inaugural issue of New Dawn, the Journal of Black Canadian Studies, which was in the spring of 2006. Black Studies provides a necessary intervention in the field of medical education and public health in Canada, and within discussions of Black health equity. This was the case before the resurgence of Black Lives Matter in May 2019, and before the implications of COVID-19 in Black diasporic communities. Like outbreaks and epidemics before, the pandemic reminds us that medicine, medical practice, and health do not live outside of culture. Black studies as a field of inquiry and method is a crucial intervention in medical education and public health. Debates and discourses in the humanities and social sciences encourage scholars, academics, activists, and practitioners to document and identify medical racism alongside a detailed interrogation of the parameters and matrices of what constitutes health and the colonial Eurocentric frameworks of the existing healthcare systems. Education in the sciences, including medicine, have ceded conversations on race and racism to the humanities. The supposed objectivity of the scientific approach precludes racism. It relies instead on these racist tropes of biological truisms of race. Thus supporting the myth of a racist-free practice or study or field. This worldview has surprisingly continued to thrive and has proven deadly to Black and Indigenous people. So I just want to pick up on a suggestion made by Camille Orridge in last year's lecture. In that session, Camille urged us to read Dion Brand's July 20th piece in the Toronto Star on narrative reckoning and the calculus of living and dying. I just want to add, if you've not read it, please do, it's online. If you have read it, go back and read it again. So since my next slides are being, spoiler alerted, I pick up on Dion Brand's last couple of sentences, which read, and I quote, "The X-ray that is the novel coronavirus exposes once again the bare bones of the social structure in which for Black and Indigenous people, governance equals policing, governance as violence. This we fear, this we know, that all of our thoughts will be rushed into editorial pages, used in committee meetings, all the rich imaginings of activists and thinkers who urge us to live otherwise may be disappeared, modified into reform and inclusion, equity, and diversity and palliation," end quote. I want to engage with this idea of palliation as a way to speak on health equity disparities and radical community commitments. As we may know, to palliate is to alleviate a symptom without curing the underlying medical condition. Palliation in relation to the end-of-life care is the relief of symptoms and suffering caused, for example, by cancer and other eventually fatal conditions. Palliation helps a patient to feel more comfortable and improves quality at the end of life, but does not cure the disease. Palliation of symptoms is a key goal of care for both end-of-life and palliative care. While there are uses, obviously, for palliative care and a palliation of symptoms, I think we must be cautious with how we accept and engage in palliation in relation to our community and our community's health and wellness. So it raises for me a few questions. Will we accept a seat at the table as a relief to the continued violence of and within the state, including public health? Will we accept more ethno-racially diverse people, but not necessarily a change in message? Is this the relief, the palliation to the eventual fatal conditions of police brutality, health disparities, health inequities, medical racism, and the lack of access to care? I think of these questions in this current moment. Black people remain living in moments with multiple public health crises. Currently, COVID-19, police brutality, and anti-Black racism. Racism impacts our health. Racist responses to COVID-19 continue to place all of us at greater risk. We are living in deadly pandemics, perpetual states of emergency. These are the effects of structural and systemic racism, colonialism, and anti-Black racism. And as Dion Brand states in this article, what the COVID-19 pandemic has done is expose even further the endoskeleton of the world. At the beginning of the pandemic, their claim that COVID-19 and its associated medical and social responses do not discriminate belies the history of how pandemics work and who is most impacted by them. Various chief medical officers from across the country were claiming that they do not see color, that COVID does not discriminate, that they treat everyone the same, and that now was not the time to do anything about these issues of race, especially address systemic racism. We witnessed and experienced this endoskeleton rollout in the Atlantic bubble, when blame for community spread led to increased harm and criminalized practices of Black people by the state and by public health. Black people have been victimized by unfair and criminal policing practices. Black people have been victimized by health disparities and inequities. The early Canadian disaggregated race-based data on COVID-19 identifies racism as a clear risk factor for COVID-19, and yet Black people are not thought of as victims in need of care and support, but as perpetrators who should be punished, ostracized, and incarcerated. Nova Scotia, so I have 3 vignettes, very quick. Nova Scotia, at an April 7th, 2020 briefing, the then Premier and current Chief Medical Officer scolded residents of the Preston Township for breaking public health orders and spreading COVID-19. This was the first time we saw a shift in tone at this time. Previously, the Chief Medical Officer and the then Premier encouraged people not to call the police on their neighbors, but instead to reach out to see if there were any supports needed. Up until this point, the Chief Medical Officer had refused to name communities that had clusters until one occurred in the African Nova Scotian community. And here, this is the image of what you'll see when you enter in North Preston. If you've not been to Nova Scotia, go. If you've been to Nova Scotia but not been to North Preston, go. And go on a Sunday and attend one of the historical Black churches. It's a must be at piece. So the then Premier and the Chief Medical Officer's behavior and language exacerbated longstanding anti-Black racial tensions, furthering stigmatizing members of the Preston Township. And the resulting backlash against the community signaled yet again the longstanding act of racism in the region. Little thought or kindness was extended to the Preston Township. Naming the cluster area only served to call for greater surveillance and more punitive responses. And as we know, punishment is not an appropriate public health response. It exacerbates and furthers illness. In New Brunswick, in May 2020, Premier Higgs revealed that the name of a physician believed to have spread COVID-19 and break health protocols was passed on to the Mounties to determine if charges should be laid related to community spread. And although the Premier and Registrar of the College of Physicians and Surgeons of New Brunswick claimed they could not speak about the events, they provided enough information that served to identify the doctor. Much like the Premier of Nova Scotia, the Premier of New Brunswick chose to stoke the fires of fear by calling the not yet publicly named person an irresponsible individual, which only served to call for more intolerance and violence. As we may know, once identified, Dr. Ngola became the target of racist violence, harassment, including death threats. Publicly considering charging Dr. Ngola is an overreaction and was an overreaction and reflected how COVID-19 was being used to further criminalize Black people. There have been no calls to charge any other non-Black physician, but Dr. Ngola was named. He was repeatedly identified despite no charges being laid, described as being from the Congo and therefore not fully Canadian, had unsubstantiated allegations reproduced, and had identifying information about him published. As we know, Dr. Ngola hired a private investigator to conduct his own investigation into the claims made against him, an investigation that wasn't fully realized through public health. And then in Prince Edward Island, and here I'm really just focusing on how anti-Blackness showed up in the Atlantic bubble. In July 2020, a young Francophone Black man was arrested and charged with violating Public Health Act and PEI. Javon Nsengera, 22, an international student from the Congo, who had been living in Canada for a few years learning English, became the only person in Canada to be jailed in an alleged violation of COVID-19 protocols. As a visiting student, we have to ask, what local supports does Javon have, did he have, that are needed to support self-isolation? And why did the province not provide those supports to Javon? If Javon had broken quarantine, why not find out what supports were needed for him to maintain self-isolation? The push for punitive measures often harms those most vulnerable. In each of these above situations, community intervened to counteract state violence and to provide direct mutual aid to each other. And by mutual aid, I mean local structures of cooperation rather than relying solely on the state to address needs. Sorry, not yet. Responses to state violence and health inequities include radical community commitments. And so I want to speak just briefly here. I'm going to open up my chat so I can see how I'm doing for time. I'm almost there. Please text me in chat. Okay, perfect. Thank you. In 1972, the Black Panther Party included health as part of their mission, calling on the government to provide free of charge for the people health facilities which will not only treat our illnesses, they state, but which have come about as a result of continued anti-Black racism. And they also spoke about health as a way to develop preventative medical programs. In addition, the Black Panther Party called on researchers to provide Black people with access to scientific and medical information so we may provide ourselves with proper medical attention and care. In 2017, so Black Panthers 1972, in 2017, Drs. Moya Bailey and Whitney Peoples published an article titled Towards a Black Feminist Health Science Studies, and they make the same demand. They argue that health and wellness must be seen as an integral part of social justice labor. This means activist doctors and healthcare practitioners must be working with and within, in my example, African, Nova Scotian, and Black communities. And so I use the word activist here on purpose. While this may be off-putting for some physicians and healthcare practitioners who may be more comfortable with being positioned as advocates, activism is what is needed. So while mutual aid was the focus, and I'm going to talk a bit about how mutual aid came in these community spaces. There were still conversations about how to engage the state and public health, and this was not uniformly agreed upon, but ultimately becomes a tapestry of these responses. So in North Preston, I really want to honor the Black women, the young Black women who stepped in and created the initial North Preston Rapid Response Team. They created this team to go in and provide supports to community members, to make sure that they had food coming in, to make sure that they could strategize around how to self-isolate in homes that were multi-generational, and of course, in a neighborhood where people were underhoused, or how to provide services for those who were houseless. The North Preston Rapid Response Team ultimately was created, the African Nova Scotian pandemic response. It went from a local setting to the provincial setting. The North Preston Rapid Response Team also engaged in held community meetings, wrote an open letter demanding creation of culturally responsive pandemics to the then Premier and the Chief Medical Officer. And as I said, provided resources, grocery cards, access to technology, fellowship to community. In relation to Dr. Ngola, he left New Brunswick and is pursuing legal remedies. And I don't have an up-to-date any updates on what's happening there. But his leaving also meant that a small, primarily Indigenous community was left without a physician. The province, as I said, focused on punishing and criminalizing Dr. Ngola and did not focus on his needs nor the needs of the community, and ultimately did not meet those needs. And in terms of Javon, he was found guilty and is now on a 2-year probation for breaching public health protocols. We should be enraged by these things. But the community did surround him. They reached out to Nova Scotia, reached out to New Brunswick to come and provide supports in PEI. And they continue to work through mutual aid, through transformative justice, to provide community supports, not only to Javon, but to Black communities in PEI. And I want to just talk about this slide here, which speaks to the Health Association of African Canadians, which is a community health resource. It's not a community health center that you would see in Ontario, but it is a community health resource. They have stepped in from the beginning, offering town halls. So as soon as Nova Scotia went into shelter in place in March 2020, they held a town hall for African Nova Scotians across the province and for Black communities across the province. That poster is not here, but it was one of the first sessions that directly spoke to Black people and African Nova Scotians and Black Scotians in the province. Up until this point, there was nothing specifically related to Black communities from public health, other than being named as being a site of problem and a site of danger. And so in this meeting, chaired by Health Association for African Nova Scotians, but they also drew on local resources. So Black physicians, the Deputy Minister of Public Health, other Black health practitioners to provide resources. And here are just some of the other, just 2 examples of the other town halls that have continued to happen, one on vaccines and one on vaccine passports. So centering the experience of Black health practitioners and resources in the province and beyond, but also establishing Health Association, the North Preston Rapid Response Team, establishing vaccine clinics, testing clinics, and working with trusted health members of the community as a way to disrupt and step away from the really well-founded mistrust that African Nova Scotian and Black people have with the government and with public health. But I want to return to palliation and the warning of, all of these rich imaginings of activists and thinkers who urge us to live otherwise may be disappeared, modified into reform, and inclusion, equity, diversity, and as Dion said, palliation. While there are community members who resist working with the state, there are other members of our community who insist on a presence. For some, this may be thought of as a form of harm reduction, the implementation of policy and programs and practices that are to minimize harm, in this case, to minimize racism. The harm reduction is not focused on minimizing behavior of Black people, but must be focused on the systems of anti-Black racism that ultimately have a negative physiological effect on our bodies and our minds. So while there is on the ground research and intervention happening, there's also the committee meetings, the meetings with public health officers and departments to get resources for Black communities, for example, as I said, vaccines, testing, and other supports, while also demanding accountability, which is still needs to be realized. There are meetings with new provincial government in Nova Scotia to argue for high-level representation of African Nova Scotians and Black people in health. There is the continued push to have better representation within. But my question here is, what is the moment, what is that line where this becomes palliation, feeling better, but not really disrupting the anti-Black racism that brings illness and death? There are numerous examples of how we can get research wrong and how it is developed and how it is evolved and how the construction and the purpose and the research. What we don't want to do is be extractive, which is, of course, the base level of mutual aid and care. So I'm thankful for the scholars, the researchers, the community activists who engage in this labor, for the direction provided to us on how to best engage community-based research that holds all of the realities and remain committed to creating and sustaining livable Black lives. And that's kind of what I wanted to offer today. It's like, what are these realities that we're faced with during COVID, and what is made available to us, and how do we engage in that? Because we are also part of these communities, but not to be extractive, to be committed to, shared, for example, community-led data governance, or committed to new systems of care for isolated Black communities, those living rurally without primary care or access to services, or those who continue to be involved in community-led research and directing those research funds to community-based projects and interventions. So the findings facilitate community beneficial tools as opposed to the extractive state reports. So these are just some of the Black studies methods engaged in the caution of palliation that help us to foster a dialogue on health equity as it relates to community advocacy, community engagement, and community level work, from targeting community-based engaged perspectives to inequalities and inequities seen during COVID-19, and why it is important to tackle inequities in healthcare amongst all other issues. So I think I'll stop there. I don't know what time it is. I'll stop there, and I look forward to my conversation and our conversation with colleagues.
That's terrific. Thank you so much, Dr. Dryden. You are not even a minute over. You're perfectly fine. So we really appreciate that. I could ask you a million questions right now, but I'll hold them for our group discussion. But just want to send much respect and much gratitude your way for everything that you're doing and all the community voices you are bringing along. Okay, so the next speaker we have is Cody Bernard, who I mentioned works with Ontario Health on a variety of equity-related issues. I've gotten to know Cody this year, and it's been a real pleasure, and not just because I love the orchid in his shot. So Cody, I will turn it over to you with much thanks.
Yeah, thank you for that, Arjumand, and thank you for that, Dr. Dryden, as well. My name is Cody Bernard. My pronouns are he, him. I am zooming in from Toronto, the traditional land of the Huron-Wendat, the Haudenosaunee, and the Mississaugas of the Credit. And I am happy to be here and then speak with you virtually today. I just actually was taking a few quick did a few notes from Dr. Dryden's remarks, and I took your advice. I was listening to you carefully, but I did take a look at that article by Dion Brand. I just want to start off by reading a few sentences from there, from that article. All my life, I have lived with the chronic fever of anti-Black racism. So many of us have, and for so many years, generations. I know this as I go through my daily acrimonious back and forth with the commentators, experts, and politicians as they attempt to manage the pandemic as narrative, as calculus, but not yet as reckoning. I know, as many do, that I've been living in a pandemic all my life. It is structural rather than viral. It is the global state of emergency of anti-Blackness. What the COVID-19 pandemic has done is expose even further the endoskeleton of the world. So I'll be brief in my remarks because I do actually want to spend some time with the questions, but I did want to kind of highlight some of the things that came to me in listening to you speak, and also speak a little bit about some of the experiences that we've seen here in Ontario, looking at it from the lens perhaps more so where from I sit is within the healthcare system. And so I first want to start off by acknowledging that COVID and the inequities that we see during COVID, they really pre-existed this pandemic. In many parts, we knew that this would happen. What would be happening to Black, Indigenous, and racialized, as well as low-income peoples during this pandemic, and we saw that happening. We saw increased rates of COVID-19 infection in racialized communities. We saw high rates of hospitalization. We also saw hospitalization that was happening at younger folks for Black and other racialized communities. That they were much younger rates of younger age when they were hospitalized than that of white populations. We also saw that, and I'm thinking more particularly in the Toronto experience, but we could say this writ large, inequities in terms of our vaccine allocation. So in neighborhoods that had the highest percentage of positivity, saw very low vaccine rates. And all of these things that we saw were really coming out of kind of the structures that we already see in place within many of the communities that we are looking to meet, or looking to engage with. And I think one of the things that I just wanted to comment on too is, as you spoke about, the need for connecting in with communities. I found it rather curious that in many respects, as we did try and do a lot of targeted outreach, when there was a need to kind of engage with Black communities or find out where Black folks are in order to, increase vaccine rates and things of that nature. Many of these communities, our communities that we sit within, have been invisibilized throughout this whole pandemic and prior to, in that there was not a really understanding as to where folks are, how to get to them, how to even speak to these communities, and it really just highlighted an issue that we knew was in existence, but it really just spoke to the fact that in no ways where was the system really equipped to address the needs of these communities. And so it really demonstrated that there's a need to have more involved kind of community partnership on many different levels and engage with community activism in different ways. So when you spoke about activism, I think that we need to kind of think about activism on a continuum and need to see it coming together at many different levels. We often think about the on-the-ground work, the folks who are in the streets, who are leading those kinds of efforts, but those efforts need not be in and of themselves. We can't have people at demonstrations on their own without connecting to a broader, support system of work and connection to others. So I think about, the work that you're doing and you're leading, Dr. Dryden and others, and the need for activists to be connected with activists working in academia and education, to connecting with folks like you and your peers. The need for activists to be working at a clinical level. So when I know we'll hear shortly from Dr. Shush and the work that she's leading, we need to talk about, how we can engage and connect with student activists who continue to lead important work and don't often get the recognition in terms of the leadership that they provide in providing innovative and new ways to challenge kind of our status quo and think about how we can do things better. And all of that work, I think, needs to be redone in and alongside folks who are in the community who are doing this work. I think about two examples when I think about how we need to, when we speak to kind of connecting to different fronts. When I think about, focusing on the needs, we saw a lot of work that was happening during this pandemic around, folks who are in shelters or with homeless populations, and then recognize that what this pandemic really highlighted is there's actually not a lot of work and activism that we see prominently forefronted or supported to address the needs of the working poor. That was a real issue that was highlighted during this pandemic, and where was the kind of the support system needed to address the folks who were on those buses that we saw during the pandemic, in the height of the pandemic, where there were high transmission rates. Where all the people who were in these positions who are deemed essential workers, working primarily low-wage work and having multi-family home units where they didn't have the opportunity to kind of self-isolate and things of that nature. I think another piece too that I speak to is that there was a moment in time where we did see a lot of folks coming in and having a different, having these declarative statements in terms of their support for Black, Indigenous, and racialized folks and a commitment to doing this work. There was a moment where we recognized that folks working at the system level really needed to have data to really inform some of the work that they were looking for, that they were needing to be done, and there were commitments to doing this work. But then in the height of the pandemic, there was a lot of folks who kind of stopped doing that. Much of the system kind of recognized that when the pressure got tough, these are the first things that were dropped. Fortunately, there were folks like the Black Health Equity Working Group and others who were able to come together to recognize that there's a need for system change to support that delivery, but also recognize that they need to pivot immediately to kind of respond to the shortfalls of the healthcare system in that moment, to ensure that the data was collected and being used as it needed to be to target kind of investments and response during this pandemic. So I think that just, briefly wanting to touch upon kind of some of that activist work and then tie that into some of the work that we're seeing in the healthcare system. If I can narrow it just a bit in terms of, some of the things that I think are not really focused on in the system at large. So in many ways, we look at this healthcare system and it really is responding to, what many others refer to as the sick care system. We know in many of our communities, we don't have access even to that sick care system. We face, incredible long wait times for mental health and addiction services, limited and sometimes none at all access to primary care. These are issues that are rampant within Black and Indigenous communities in particular. We often are not getting access to good food. We, and as a good care. And as a result of that, we have poor experiences in the healthcare system and therefore also poor outcomes. We have, poor access to good screening, good screening where we see kind of high screening rates in cancer and other areas. Many of our communities aren't really meeting the needs, meeting the targets that we need to do when we do a deeper dive. And so I think that when we think about access to good care and good health, we need to be thinking about what are the broader areas of health when we're thinking about those social determinants. How are we addressing housing? How are we looking at addressing livable wage and addressing these broader social determinants of health, which are all kind of issues that I think we saw quite prominent during this pandemic. I think I'm actually, I may have gone over time, so I think I might just stop there and then I'll return to this in our Q&A portion.
No problem at all. We have plenty of time. Thank you very much, Corey. Really appreciate that. Again, I could start rattling off lots of questions for you right now, but I'll save them. And I'm pleased now to introduce Dr. Suzanne Schusch, who will talk to us a little bit about her perspectives. Thank you.
Hi, thank you guys so much. Honestly, this has been an incredible conversation and it's incredible to be a part of it. You can probably hear I'm over at the Call Auntie Clinic where there's always laughter and joy. So there's always a lot of noise here. It's interesting. I just want to really thank everyone who spoke before me and thank Sabrina Vohra Miller. This is really wonderful to be a part of this panel discussion. We're really here talking about the context of two pandemics, the pandemic of racism that's been going on for centuries, and then the pandemic of associated poverty and poor health, criminalization, issues with the justice system, and of course the pandemic of COVID. And I think that more and more we're all understanding that really the number one social determinant of health is truly privilege, right? And we're looking at a situation in which that the most effective and assured way that you will remain healthy and safe through a pandemic is truly through having privilege. It's not through having access to a physician or prescriptions. Well, yes, that is part of it, but a huge part of it is having political influence and having economic power. I feel like we come to these discussions and we're always preaching to the choir, and I keep hopefully checking the participant list to see if Doug Ford has signed on yet, but I don't know if that's going to happen. But I really want to see that, these healthcare systems are designed for the inequities that we see, right? If we think about the evolution of our society, the evolution of our healthcare system, the evolution of our criminal justice system, what we really know is that these systems were not only not designed with Indigenous and Black people in mind, they were actually designed explicitly without the consent of Indigenous and Black people. So the way that we've structured our laws, the way that we've structured our healthcare systems, the way that, like Corey calls it, the sick care system, the way that we focus on disease after it has happened, the way that we are criminalizing various aspects of structural racism and structural exclusion, that really speaks to the way the system was designed, who it was designed for, and who it was not designed for. So Indigenous and Black communities are not going to be at a equal starting point for accessing really anything, whether that's healthcare, education, access to solid employment, cultural well-being. All of these aspects of our wellness are really coming from a different place of access. I think that one of the things that's really interesting that Corey touched on was talking about the research, and Omishore also was discussing research and the importance of community representation in research data gathering. And I think that one of the other things that's so incredibly important is to think about the community ownership of the data that is then collected. I think that there has to be always a view on the custodianship and the ownership of data. I think if the communities are the subject of evaluations and research, it does actually have to come through the responsibility that the communities can actually manage that data. Community representation is hugely important. And I know that it feels like, the word of the year is equity, diversity, and inclusion. And I think that every single company and corporation and university and department now has an EDI officer. And I think that that's a step in the right direction. I also think that we have to really think carefully around community representation. What does it mean and how is it inclusive? We always risk tokenism, and that's something that is very, very hard to overcome. It's very difficult to push past that being that one Indigenous person or that one Black person in the room at the table. I think that one person is their voice is obviously important, but I think that making things in a broader context, looking at who are you accountable to. One of the things that we were discussing a lot in the Indigenous community is that we're really lucky to have these incredibly strong systems of Indigenous knowledge that are rooted in community, in the tradition of community knowledge being held by knowledge keepers and elders. And what we often do when I'm invited to speak at a panel or a discussion or be at a table or join, any group, I'll often decline to come as the individual Indigenous person, but I will often ask them to invite an Indigenous agency or an Indigenous community. I don't think that there is any world in which I would speak for all Indigenous people. I'm not a chief, and that's what they're for. But I also think that it's really important to take away the expectation that one person can speak for the whole community, that there's nowhere else that we see that expectation. I also think that, when Omishore was speaking so much about just like the grassroots of community protection, that's something that is actually incredibly powerful, incredibly effective, and incredibly doable. I think that the work that we've done in the pandemic with the Indigenous community here in Toronto has highlighted some of our amazing strengths that I think were really underestimated before the pandemic struck. Our community really did band together. We created incredible systems of support, material support, contact tracing, isolation, same-day testing, material support, spiritual support, isolation support. There has been, this incredible grassroots movement of pushing and creating and developing health equity, and a lot of that is coming from the diversity of healthcare leaders now. Just never underestimate the importance of diversity anywhere you are. It's incredibly important, not just the ethnic and the racial diversity, but the diversity of all walks of life. So making sure that there is diversity in the background economically, education-wise, and in really all aspects. So I also don't want to speak for a long time. I'm really looking forward to the conversation that we can have, and I will end it there and look forward to the questions.
Thank you so much, Suzanne. This is terrific. I'm going to ask Corey and Omishore to come back on screen so that we can proceed to dig into what the three of you discussed, which was just terrific. I really, really appreciate this so much. And as I mentioned, there's so much I could ask, but let me start with some of the things that jumped out to me most. I think a common thread between the three of you was this issue of how communities interact with systems and the state. And I'm sort of wondering about two things. One is whether you could say a little bit about how you think the communities that you have been interacting with, that you're embedded in, have been viewing the state going into the pandemic. What were the sort of contexts for their sort of ideas and thinking? We've talked about a lot of this, and I think we know a lot of this, but it would be really interesting to hear what you hear from them. And the second piece of that is about the fact that, Corey mentioned, like, we knew this. A lot of us knew this equity issue would certainly be present for COVID, because it's present in every other aspect of life and for every other disease of which we know. I'm wondering if this issue of how communities view the state has hit different during the pandemic or not. Do communities sort of express any change? Is it just a turbocharged time to deal with this stuff? What is your sense of how the community is situating itself in relation to systems, in relation to the state, sort of entering COVID and then sort of during the pandemic? Why don't we start with Dr. Dryden?
Not a small question at all. As I said, I've only been in Nova Scotia since May 2019 and been in Halifax primarily for all of that. And so I have a little hesitation speaking about, what some of the broader conversations are amongst African Nova Scotian, Black Scotian, and Black communities in Nova Scotia. What I've been able to glean, and there's lots of people like doing great work in Nova Scotia, so let me shout them out while I do this. Dr. Senator Wanda Thomas Bernard, who does fantastic work, has done work on Black women in health and Black women in need of safe spaces to be as they're leaving gendered violence. My colleague and sister, Dr. Barbara Hamilton Hinch, who amazing work, both are African Nova Scotian, Indigenous Black people in Nova Scotia. And of course, the Health Association for African Canadians and Mrs. Sharon Davis Murdoch. And then of course, my colleague who just left Nova Scotia and has moved to Ontario, I'm trying not to be salty, Dr. Ingrid Waldron, whose work was the basis of There's Something in the Water that was at TIFF, right? So there's this work. So I glean from them. And also, of course, I live in this community. And so being in our conversation. But, what's interesting about African Nova Scotians, the oldest Black community in Canada, and the state, is that we are still dealing with the fallout from the destruction of Africville, still dealing with that fallout. The Wortley report, not Wortley, that's Ontario. The latest report on policing identified that 1 in 6 people stopped by police are African Nova Scotian for no reason. And in Nova Scotia, it's called street checks, not carding. And then the continued stigmatization of areas like North Preston and the ways in which systemic barriers continue to work negatively in and amongst African Nova Scotian communities. So you have this, and I did a really poor job in kind of capturing all of that. But you have these experiences that then, where people are working with the state in various ways, right, to try and make interventions, to try and have reparations, to try and have resolution, right? So there's still resolutions that need to happen around Africville. And then you have this piece around the pandemic. So in January 2020, when we were hearing about COVID, the coronavirus, I tweeted, as this becomes an outbreak, we need to be careful not to racialize, transmission. And then this is what we started to see happen amongst a variety of Asian communities, right? Who became Asian communities, right? This one kind of monolithic piece. But then we started to see the significations of transmission happen through Blackness in the Atlantic bubble. And so it became a resurgence of rage and disappointment and pain to like, how are we as Black people being exponentially affected by COVID? And in response to that, you're blaming us for contracting COVID, right? You're claiming that we're going to cross the bridge, right? Go from Dartmouth to Halifax and bring COVID to predominantly white communities, right? So to say that, to this day, still not have accountability or an apology for that. And then with the change in government, this was further exasperated because the change in government came in. Nova Scotia has a Ministry for African Nova Scotian Affairs. We had Tony Ince, African Nova Scotian person, was the Minister for African Nova Scotian Affairs. With the new government, there's now an all-white cabinet, and there's now a white man who's the Minister of African Nova Scotian Affairs, and who has said typically white things like, I know Black people, I'm here to be a voice for Black people, to speak on their behalf. And this is why I say it's important for us to engage in activism and not advocacy. We don't need people to speak on our behalf. African Nova Scotians have a voice. So this piece to come in like, oh, I'll hear what you have to say and then, do for you. It's very patronizing. And so some of the initial actions taken by the new government have again further exacerbated whatever relations that were being developed between and among African Nova Scotian communities in the state. The other difficulty is that African Nova Scotians aren't considered a unique community per se that can have a community-based relationship with the state. And so it works to diminish their historical significance and ultimately treat them as just Black communities without this kind of historical reality. And that really also serves to cause mistrust and distrust. And if there are African Nova Scotians in the webinar, please add to the questions and please provide information I may have missed. So that's what I would offer. I'm not sure if I answered your question, but that's kind of that's what I see as just a portion of the climate, or what Christina Sharp, Dr. Christina Sharp would call the weather that's happening in Nova Scotia.
It's really helpful. Thank you so much. And I'll go next to Cody Bernard, but just before I do, I'll just invite our audience again to add any questions they have to our question and our Q&A option, and we'll pull questions from there after this panel discussion. Thanks so much. Cody, please go ahead.
Yeah, thank you. Interestingly enough, it's so interesting hearing you speak, Dr. Dryden, about what's happening in Nova Scotia and how similar kind of the reverberations of anti-Black racism kind of happen across this this Canadian landscape, and that there are many similar kind of experiences I think that we saw here in Ontario as well. If I can think a little bit of I guess the question around how communities view the state and interact with the state, I'm reluctant to kind of speak to the first part around how communities view the state, because I think there are many communities, and that I think we're quite of a diverse group, and so I think there's different viewpoints, and I think that's healthy and important to recognize. In terms of their interactions with the state, so in some of my experiences and what I've observed is I do think that there has been quite a difference in terms of how communities have been engaging with the state. One of the key things is that I think that communities are organized in a way that we haven't seen in many years. So I think that the expectations of communities, the expectations from communities of the state are quite kind of clearly articulated and prominent, and many community groups are not willing to kind of return to whatever the moment was, prior to the pandemic, and are also very much aware and activated in articulating kind of what it is that they need to see out of this, coming out of this pandemic, during this pandemic, and also following it. And so there isn't really an opportunity to do the same kind of ignoring or dismissing that we may have seen in the past. So I think that that's a real positive outcome. I would also say that, I spoke to this a little bit earlier, and so did Dr. Dryden, in terms of a lot of the, well-intentioned, or not well-informed distrust of the state. And we see this as a challenge in responding to COVID-19, in thinking about building, and shifting our attention or in parallel to some of our recovery efforts. I think that the engagement that we have within community, and recognizing that those relationships were not established in many ways, or not as strong as they needed to be, is a real need to focus on that and have some real targeted investments in doing that. And we see the benefits of when communities are activated and activism is engaged as part of that process. The response rates in terms of how people are responding and taking care of themselves have been much better. And that other last piece, I would say, in terms of that self-care piece and recognizing where we have leadership within community, that can actually, respond to their needs, identify what is needed, implement them, when provided the resources and supports to do that, and the parameters and the broader kind of policy considerations that need to be put into place. Many in community can take care of their own. And I think we've seen that. So now that's a real shift that we're seeing in terms of how folks are interacting with the state. The last, I guess, few kind of quick comments I just want to make on this front are the connections that we have also, in terms of, not just thinking about our local politic and things of that nature, but more broadly. Actually, there's 2 points that come to my mind. So one is just, I'm thinking about, when we think about distrust and of the state, we also recognize that many of us are connected to other places. And so even while we are talking about things like vaccine allocation and vaccination rates and things of that nature, many of us have loved ones who are residing in places where we are not seeing the vaccine available to our loved ones. So I think that there's sometimes a conflict as well at play, even for those who are really seeking to get the vaccine and support. And just broadly, when we think about some of, the sometimes maybe I'm speaking for myself, but the guilt that some of us may experience as well, and what we're expecting from our government in terms of taking care of, not only taking care of me in Ontario, but also ensuring that Dr. Dryden is taking care of in Halifax and the broader community in Preston, and me thinking about my loved ones and family members in the Caribbean and elsewhere. Are those folks taken care of? So ensuring that, I'm not operating in a space where I'm trying to duck and dive and avoid anti-Black racism, as long as it doesn't hit me, but then it impacts my other folks who look like me or family members in a different way. So I think that is one piece. The last thing I will say actually on this front quickly that I think that is also rather interesting is just when we think about the time, some of the policies that we've seen come out during this pandemic. I think about, and I'm thinking this, Dr. Dryden, when you were talking about the street checks, and I'm thinking about, different kinds of policies that were in place when we did have stay-at-home restrictions, and the fear that I had as a 6'4" Black man, thinking about what my experience would be walking the streets with some of these policies in place, knowing that I'm working within a system. And understanding what we're doing to kind of protect and ensure that we're responding in positive ways to this pandemic to make folks safe. But then what that looks like for me, that's a bit of a different experience. And I also think about that from the very onset of thinking about walking into public spaces with a mask on and things of that nature. And I think that those types of things continue to occur. And so, these are some of the things that we grapple with within community when we think about responding to the policies that are in our best interest, but then the implications that has on us in living and adhering to them.
That's fantastic, Corey. I think I've picked up on a lot of what you said, but one of the things that sticks out to me is how simultaneously intimate and yet global community is for Black people, right? So that we're all connected in so many different ways. So it makes the term community really important to sort of interrogate and understand. Suzanne, did you have anything to add to this conversation about communities and how they're viewing the state and interacting with the state and expecting of the state?
Yeah, so I do think that these communities that are disproportionately impacted by COVID are the exact communities that have had a historical complicated relationship with the state, and that includes with our healthcare system. You know, when we have this healthcare trust gap that is very significant and is ingrained and has not been addressed in the past, it's really difficult to come and address it during a pandemic. So when you're having a healthcare crisis that is impacting Black and Indigenous communities, if you were not a part of those communities before the pandemic, it's going to be very hard for you to come in and tell those communities what to do. And that does not matter what advice you're giving them. I think that one of the, trying to understand the significance of trust in good health is really important. Like I mentioned before, you can take it all the way back to the transatlantic slave trade, to colonization, to the Tuskegee experiments, to Indian residential school systems. But at the end of the day, it is also contemporary racism that destroys and erodes trust. So everyday exposure to chronic acts of racism makes people want to protect themselves. During this pandemic, at the beginning of the pandemic, we really thought that this pandemic could pose an existential threat to Indigenous people, just like the pandemics before have. And we were really worried about simple things like contact tracing, because what community member wants to be called by a stranger from public health to be grilled about where they've been, who they were with, and what they did? We actually, for that very reason, started our own contact tracing program for the Indigenous community. And we reached out to Partners in Health, which is an incredible international NGO, and they provided us with some expert contact tracing that was based on the community-based contact tracing programs that they started during the Ebola outbreaks in West Africa. It was really effective. And so we have our own systems of actually making sure that we're keeping our community safe, because we deeply understand our Call Auntie network, our Call Auntie clinic. We were in the community doing work in the community long before this pandemic started. We didn't just appear out of nowhere. So I think that having that trust, and again, it comes back to the diversity within the groups that you have, are going to be really important if there's a public health crisis. Because if this pandemic continues to live within the Black community and the Indigenous community and other communities of color, every single person in Canada and across the world is going to pay those consequences. And it often does take something like a public health consequence where the actual health of your neighbor impacts you to actually to make policy changes and policy differences. If the opioid crisis was contagious, I'm sure we would act more on it. But we don't see it as contagious. We see it as behavioral failing of one or two people. I think that when you have, it really gives you a moment to stop and reflect on like how we value things and how we create systems. Like Corey mentioned, that moment of horror when the government was trying to grant the police increased powers for surveillance and apprehension and questioning, I truly wonder if there would have been the same outrage if that had not been simultaneously released with the decision to close playgrounds, because that involved the broader community. It wasn't just Black people and Indigenous people crying out. It was every single person in society. And that really helped. And, we do have a lot of trauma to thank for getting us to this point. We have Joyce Echaquan to thank for getting us here. We have George Floyd to thank for getting us here. And, that gratitude can never be justified for what happened to those people. But I think that those moments caused such a huge shift in our perspective that we're starting to understand these structures.
It's really powerful. Thank you. I want to talk a little bit more about systems in the state in relation to communities. One sort of area of work that I think really came to the fore during the pandemic was the issue of data collection. And I remember us in Suzanne, in your talk, you talked about data governance. I think both Corey and Omishre touched on sort of information and information governance. Can you talk a little bit about what you saw from your perspective as embedded in the community, but also working with communities? what you sensed were the discourses. What are your thoughts about not just whether we should collect data, though of course I'd love to hear from you about that, but more about what you think the issues are that are involved. And in some ways, this is very connected to the thoughts that you've been expressing about the relationship between the community and the state in general, in terms of what's led up to the pandemic. What are the relationships like that pre-exist? So in moments where we think about something like information collection of various sorts, we're doing that against the backdrop of a lot of trauma and a lot of failings to protect human rights, to protect, fundamental sort of resources and so on. So if you could talk a little bit about your conversations, your thoughts, your reflections on collection of race-based data and other data that have kind of really sprung up during the pandemic. And Amisha, I'll go to you first.
I do think we should collect data. I think we have some data. I think we have some data that we've collected through various community-based research initiatives, right? So we have documented first-person experiences that are collected through focus groups, through community meetings, that kind of thing. And the state, right, or public health or decision makers in health have often said that that's not evidence enough or that's not rigorous enough. And so they've used this excuse as a way to discount that. That's part of, I think, some of the underlying desires for disaggregated data, like let's get this data, because I saw this for many months and continue to see versions of this in Nova Scotia where they're telling us who got COVID. So they're like, of the 200 people who contracted COVID in a period of time, so many were men, so many were women. These are the age breakdowns, but that doesn't tell us. That doesn't give us the information that we need. We need to know if they're rural or urban. We need to know what the breakdown is. We need the disaggregated data. And then the concern around that is to make sure that it doesn't get weaponized in a way to further the racist notions of biological race, right? And so, as we all know, Dorothy Roberts has a great TED Talk on racism in medicine. I use it for Med 2 students when I teach in pro-comp, professional competencies. I was like, okay, let's start here. Let's have this conversation so that it doesn't get weaponized in many of the other ways it got weaponized. So I don't know if we remember the conversations that were happening in various jurisdictions in Quebec, the province, not the city. There was this desire to collect disaggregated data, and they said, we want to collect it so we can understand what the genetic reasons are that Black people are getting, COVID. And we were like, no, that's not what this means. And so in the communities conversations I've been in, and I agree with Corey, there are people, because our communities are so diverse, there are people who are like, no, you don't get that data from me. And other people who are like, well, they're already collecting so much data from us. Why not clarify that information for our use? So the shift has been not so much, again, for it to be extractive towards state and public health use, but for it to be a tool for community needs, right? And so, because the other conversation we had was, because remember at the beginning, right? We have other conversations saying, but can Black people get COVID? How do we know what the numbers are with Black people getting COVID, right? These things. And so this data then becomes, we wanted that to be self-generated, where then we own that information, that we operate the governance of that information. And then we establish the data sharing agreement with the state in terms of how they will use it. We have say over how they'll use it. So it's not perpetuating harm in the system. And this is where I really want to come back to this harm reduction model, right? And then the analysis of the data, needs to be grounded in critical race theory. So that means we begin with the understanding that racism exists, we know that racism exists. But again, right, those voices of chief public health, chief medical officers saying there's no such thing as systemic racism, saying, oh, we treat everybody the same, saying, oh, this is colorblind, as if that's equitable. Like these things, right, are why there continues to be well-developed mistrust in how state agencies will use that data. And so I think it needs to be community operated and community deciding how it's shared and then how it'll be used. But then I know that there are many community members across our provinces who want the data as a way to secure the funds needed to effectively and appropriately disrupt systemic racism in the system, but also to effectively address health inequities and health disparities, right? And I think, I still think of that as a harm reduction model. How do we reduce the anti-Black racism harm in the system that continues to harm us? But when I think of it as like a mutual aid piece, then how do we then use that data for us to provide, for us to help speak to all members of our community who have mistrust, who may not know, or who are like, well, how else can we use this to better strengthen our well-being? And this is, I think, what we can get in community, how we can strengthen our well-being, and all of us, those of us Black, queer, trans, gender non-conforming, those of us in thruples, those of us, who have connected family relationships across locations, for example, within the province and beyond this region. So all of these things, I think data can help with that. But I do understand the resistance, the hesitation to make sure that it's not deployed for their use and to our detriment.
Really interesting. I mean, I think in some ways what you're saying very much reflects what you all said earlier about the pre-existing relationship to the state and mobilizing in the face of that and connecting in the face of that and trusting in the face of that. A lot of what I'm hearing is that these are very difficult hurdles to overcome when you've had, hundreds of years of complete, decimation of societies. It's very difficult to all of a sudden be on the same page and on the same team. Corey, did you have anything?
I don't have too much to add to that. I think, I would say that it sounds, I just echo kind of, some of the sentiments that Dr. Schuss is indicated in terms of where there's good use of the data and governance for this data as well. And I think Dr. Dryden spoke about that as well. I think my challenge is, so first to answer the question, I do think that, we should collect disaggregated race-based data. I think that where I struggle with is that often is kind of the end all be all. That's the goal, is the collection of the data and not the use of the data, and the reporting of the data as well, right? So I think that the interpretation is key. The analysis and interpretation needs to include, and in many ways being directed by the folks in community who are impacted by this data, whose data it belongs to. And then really understanding how it drives, meeting the needs and priorities of communities. The two things I would say on this front, one is that, during this pandemic, I think I can speak to, at least in the Ontario experience, it was a moment when there was a shift in terms of a hotspot approach that was really looking at how we can target vaccinations into communities where they were most needed. And, that was a data-informed approach. So I think it's important to recognize that data is, a driver and something that we need to kind of look and see how we can make good use of. But we also know that, there was other kinds of stigmatization that happened. And, the best example that I often kind of cite is we saw in parts of the GTA, in Brampton and Peel in particular, we saw, a rise in rates at a particular moment in time, and then we heard kind of responses in terms of targeting, the South Asian community and saying, well, this is a result of Diwali celebrations as why, the rates were so high, which, we all know is racist and untrue. And so I think that it's really I just want to underscore, I guess, what Dr. Dryden said in terms of the use of the data and the governance. The other piece that I just want to signal as well is the deep-seated anti-Indigenous racism that are within our systems writ large. In that, there are examples of demonstrated, documented, and really well articulated and working functional systems that can articulate and describe processes for good data sovereignty and ownership that we see from Indigenous communities. And oftentimes we ignore that, and I situate myself too in communities in which I sit, where we look and trying to develop new kinds of models for things and things of that nature, when there are demonstrated cases that we could learn from, but our inabilities to kind of respect and honor those kinds of processes and structures that are in place for Indigenous peoples don't allow us then to reap the benefits of seeing how these things could be impactful for others. And I think it's important to name that as a part of not respecting and honoring these Indigenous ways of being and practices as racism, anti-Indigenous racism, is my take on that. So I do think that there's an important piece there and a real need, which I do think we are in a moment now where we are seeing greater examples of solidarity and where we can, learn from each other and align our efforts in collaboration, because I do think it is a tool of white supremacy to kind of leave these communities pitted against each other and not really having conversations, even within community, but even across communities, to see where we can look and learn on different ways and models to ensure that we have good data governance and use that meet the need of our communities.
It's really important. Suzanne.
I would agree with everything. Honestly, when I look at data collection and I'm trying to have an open mind and race-based data collection, I just think about all of the race-based data collection that we have already for Indigenous communities and how little it has changed. How we already knew how many of these communities were experiencing catastrophes in public health, in personal health, in mental health, in so many ways, in access to basic human rights and human needs, clean water. This is all essentially race-based data. We've had multiple national inquiries, including the TRC and the Inquiry into Missing and Murdered Indigenous Women and Girls and LGBTQ2S people in our country, and that is race-based data. That is race-based data that has repeatedly pointed towards a genocide happening against Indigenous people. And yet we still see these structures and these systems that perpetuate that harm. So, we didn't learn from SARS, where you can read an article in the Globe and Mail from 2003 about SARS and think that it's about 2021 COVID. We can look at what happened with H1N1, where the vast majority of people, I think it was like 30% of people hospitalized in the first wave were Indigenous, First Nations. 20% of people who died in H1N1 were First Nations. The first person in Canada to die from H1N1 was First Nations. And, this race-based data, where is it going to go? It's almost like the health research equivalent of like police body cams. It's just there to show us things that our community already knows, and we don't see change. So I'm trying to have an open mind. I do feel that when data collection is done right, the way, for example, like Dr. Janet Smiley at Well Living House does really incredible work around data governance, and I've started to really try and embrace that and see that there is value in it. But to me, I'm like, the data's there, just how long do we have to investigate the problem to make action? Like, I want to get it done. I don't want to, but anyways, that's me. But I'm having an open mind.
It's really helpful. No, I mean, I think it's a fraught issue, right? It's not totally clear what direction to go in. And I think it's a point well taken that we have all sorts of evidence that hasn't moved action, and it gives you pause for thought. Well, I'm going to open the floor now to questions from the audience, and I'll be posing them, but they don't come from me. They come from the people who have been with us for the past hour and a half and listening to all of you and sort of percolating, letting thoughts percolate as they listen to you. So let me ask you a starter question. We've been asked by the audience whether activism is still seen as protest and perhaps not working with those in authority. And if so, how do we shift perspectives on the positive, productive role of activism in making real change? Maybe I'll open the floor, see who wants to chime in first.
I'm not sure if we're supposed to make activism respectable. I think then it slips into this role of being an advocate and, wanting, engage in kind of listening and learning sessions, but not really kind of stepping into any kind of action. And so when I think of activism, I really think about a commitment to disrupt the very system that's continuing to perpetuate harm and illness and death on our lives. And I think of it that seriously, right? This isn't, when we say that racism has a physiological impact on our bodies, we mean that. We mean it takes longer to heal from surgery. We mean that it exasperates and can cause chronic illness. And because we're situated in this region we call Canada, as Black and Indigenous people, that means we may not have access to a primary care provider. So that chronic illness that's now been developed can run rampant and leech life out of our bodies until we are ill. This is why I really agree with what Suzanne was saying about how do we understand the opioid crisis? How do we understand self-medication? People think of that as a personal failing. And so I think doctors for defunding police are doing a really great job around being physicians who are activists, who are working not to try and tweak a system that was built not with us in mind, but also built not with our care in mind. And so they really are involved in how do we create different modes of care and different modes of health intervention. And so and I also, somebody asked about not being seen as political. Everything we do is a political statement. Everything we do is a political statement. Even that statement, not wanting to be seen as political, is a political statement. And so when I teach, I have a couple of sessions with Med 2 students, and I spend a lot of time with them in that very short period of time, wanting them to reflect on the kind of physician they want to be, regardless of their specialty, especially when they themselves believe that they do not benefit from systemic racism, or they themselves are not racist. Then how do they want to actually demonstrate that when they have Black patients, because they will, when they have Black colleagues, because they will, when they have Indigenous patients and colleagues, because they will. And that means taking a more proactive approach to care, naming when something terrible happens. So when Dr. Susan Moore was told by a white doctor that he was going to discharge her on a Saturday night in the cold and not tell anybody that they discharged her, there could have been an activist doctor on staff that intervened to say, this person is no longer your patient. But Dr. Moore had to go online and ask other physicians to get her transferred to a new hospital, where she subsequently died. For Joyce, if there were an activist nurse or an activist healthcare worker or an activist physician on staff, then she would not have had to record people taunting her laughing at her whilst she lay dying, right? And so it is that serious. It is that serious, right? It's not just about being racially profiled when you go to get blood work, right? And so then they like mangle up your arm in getting blood work because Black skin is tough and Black skin is dark, so they couldn't see a vein. That is not good health. That is systemic racism passing as medical education, right? That causes harm. That means you don't go back to get blood work, but you need it in order for the metrics on other care. It is that serious. It is that serious. And so I don't think it's about, and as we will tell you, right, whenever we raise issues of racism, in a meeting, I was told I was still spewing garbage, or in a meeting, it was like, well, can we just talk about equity, diversity, inclusion? I was like, no, we need to talk about anti-Black racism and anti-Indigenous racism. This is what we need to talk about, not equity, diversity, inclusion that is not situated and founded in anti-racist practice. And so it is that serious, and it's not easy, and it comes with harm. Because people will say, you're making my staff feel unsafe because you keep talking about racism. And you say that they have to be held accountable for racism. And they were a nice guy. They didn't mean this. Like, so we're gonna send them to training and a workshop to help them, with their race. That's not how that works. We really need to detangle the system as it is, because the system as it is continues to perpetuate our harm and our death. And so many more people need to understand that that's exactly what that is, and not try to reform it, but try to create something that is actually about our health and well-being. And so this is why I think we shouldn't try to make activists respectable. But we should be engaging more broadly together in these disruptive practices, because only in that rupture are there possibilities for something new.
Thank you. Corey and Suzanne.
I think the only thing I guess I want to add to what Dr. Dryden said was just I think I was alluding to this in my initial remarks, and recognizing that activism needs to happen at multiple locations, right? So I just want to re-echo, I guess, what I was saying before in terms of it happening at different spaces. Amongst clinicians, within academia, within kind of student groups, folks who are like leading demos in the streets, folks who are engaged within the system as well. I think one of the questions you ask is whether or not activism, if it's okay for activism to work and speak with those who are in positions of power, those in authority. And I think it must. I think that if it doesn't, then it does a disservice to all the folks who are actually in the streets and working in community doing that work. So I think for me, who's situated at the systems level in work within the healthcare system, I do think that it's incumbent on me to also bring some of that activism into my work. And I think that and how that looks and operates, I think is different for different folks. But I do think it needs to be connected with the work that's happening in different settings. And if we're not kind of bringing that into the various spaces to turn up our nose and say, no, we're not going to engage in activism within a certain context. Obviously, I'm not saying to be a part of kind of like foolishness anyways, I can't think of the word I'm thinking, but I'm talking about a real politic that you bring into the workplace or to whatever kind of space that you're entering. I think it's important, but I do think it would be a disservice and a disrespect to the folks who place their lives in harm's way on a daily basis, and to sit there and say we're not going to engage within the spaces that we have and opportunities to engage in activism because of a certain way it looks or how it sounds or what have you. It is disrespectful, I would say, to the folks who are engaged, and I do think we cannot do it alone. I don't think that folks who are leading work in the streets should have to be doing that work in and of themselves. I do think it needs to be connected. And people who are working in systems levels, or folks who are working within government, or folks who are working within academia, and all sorts of different places need to be a part of that conversation as well. The last 2 points I just want to say on this front quickly was, I really loved what you said, Dr. Dryden, in terms of, this is everything we do being political. Saying that many times we've seen and demonstrated clearly that many things that we doing nothing is both political and also criminal, and many times, right? So I think that we don't have the luxury oftentimes of kind of making decisions around what's political. Our bodies are political, who we love is political, how we look is political, how we show up is political, how we talk, walk, where we live is political, and many of these things interface with the system in many different ways. As I mentioned, it's and oftentimes all of those same things are also criminal, right? So how we sleep, we've seen accounts of this. So I think it's important to kind of be reminding ourselves of that. But the last thing I do want to say is when we also do think of activism, I also am reminded of Audre Lorde, who speaks on self-care as a revolutionary act. And I do think that we also need to remain activists in kind of maintaining the need and space to create any type of semblance of self-care that we can have at this time. I do think over the past 2 years, there's been a heightened sense of awareness and spotlighting on Black death, on Black trauma, on Black and not just Black alone. I'm speaking about Black in my experience, but our traumas have been spotlighted in different ways, and also has been materials for education and training, for others, right? So I do think it is important that we also I understand that part of our activism needs to be in the ability to just take care of self, to be, to exist, to love, to mourn, to come together in safe ways, and all of these kind of normal activities of daily life that have not often been afforded to us. I would see that as being activist work in and of itself, just showing up. And so I think that we need to really broaden kind of what that definition looks like.
I really appreciate that. And I can say, as someone who is part of the Black Health Equity Working Group with Corey, I feel like we show up and take care of each other when we meet. So that's always much appreciated. Suzanne, do you have any thoughts to share?
Yeah, I would say that exactly like Corey and Omishwar both said, we all are standing on the shoulders of giants. We are standing on the strength of our ancestors, on the strength of survivors of genocides, of so much violence, and we're here today. And I think that gives strength. And I tend to be in real life, I don't like speaking that much. I'm a shyer person. I don't want to necessarily talk. And then you look at, for example, the strength that survivors have to speak on what they've overcome. And then I can't give a presentation in front of a room of 250 people. Like, it just seems ridiculous. I think that there is an authenticity that you can embrace in yourself. I think that, I've tried the protest route, and I've stood in front of the police station with the megaphone, and I was like, I have good points, but I feel like I just look like a crazy person. Like, I need to be writing an op-ed. I need to be doing something different. Like, this is just not me. I'm trying. But I think that embracing your own authenticity and like how you can protest where you are, how you can protest through actions, how you can protest through changing the things that you can change and not taking no for an answer. I think that, I really think that for some reason when Corey was speaking, I was reminded of this joke that someone was saying about why is it that Black people have to make everything about race? And it's like, we weren't the ones that invented race, like, we didn't invent this, and we have to live in this, our race, Indigenous people, Black people, so many people, we are really defined through the white gaze, through the way that the society sees us, through the way that physicians see us, through healthcare providers, through nurses. I think that I've had so many conversations with so many of my patients who say that the most important person in the entire healthcare system is the person who answers the call bell when you need help. And if that person is exhausted and angry or holds biased views against you for being whatever trope of a Black person or an Indigenous person that they have, then your care is going to suffer. It doesn't matter if your doctor is not racist, right? It doesn't matter if any individual is not racist. You know, it's the systems that we create and the biases that we all walk with. And we all have to be so aware of that at all times. We have to teach our children that. We have to have those conversations. And that's something that, you know, it does make everything about race. So that's all I just wanted to add.
That's great. People who work close to me I know there's the term racialized is the en vogue term right now in Canada. And it's a term that drives me nuts because I think the intent is to distinguish non-whites from whites as if non-whites are racialized and whites are not, when, as Suzanne said, you know, the reason we have race is to protect the white race. So it's so weird to call non-whites racialized and leave free from a racial identity whites. In any case, I think we have time for one more question. And Suzanne, there's one that was directed directly at you, and I'm going to read it, but I want to broaden it to something I've been wanting to ask the three of you. So the question is stated, Dr. Shush, you talked about the need for community representation and equity. I'm wondering your thoughts on how the lack of diverse representation on our public health boards is impacting the way and ability for local municipalities, provinces to respond to health inequities. And I'd like to broaden that out a little bit and ask the three of you to reflect a little bit on what structures you think stick out to you as ones that either were particularly ineffective or that you would transform in particular ways. So, Omishore, you talked about the Ministry for African Nova Scotian Affairs. I'm not asking you necessarily to talk about them, but it's an institution that was operating. Corey, we have the Black Health Equity Working Group during the pandemic. You talked about maybe we have a need to, you know, sort of have something at different levels that's more continuous, not just in that moment, but sort of ongoing. Suzanne, you've alluded to this and the question sort of goes directly to things you said. So maybe I'll ask Suzanne to start, but if you guys could talk a little bit about sort of more specific institutional structures that either you see as not effective or that you imagine could be effective.
Yeah, absolutely. I think that the lack of diverse representation on any board leads to bad decision-making and poor decision-making. And especially when it comes to something as important and as impactful on the entire communities as public health, you have to have diversity on that board. I think that you see, you know, when there's a lack of diversity and a lack of understanding the social determinants of health that impact the communities that are struggling with COVID the most, you come up with these really bad solutions. And, you know, I remember one time listening to the radio and Ford was talking about how they wanted to spend millions of dollars on ethnic radio so that they could help all of these people who are so dumb that they don't understand English and, you know, didn't know that there was a pandemic, they could reach them. And I'm like, do you actually think that this is ethnic, like an issue of like an absence of ethnic radio stations that's driving the pandemic? You know, these are the people that are going to the warehouses, driving the Ubers, going to work. This is the people that have no choice but to keep society going so that everyone else can stay home. That the solution is not in a shift to media approach, right? You also saw some really, you know, questionable decisions about reopening after lockdowns. One of the things that we saw on the, you know, after the first lockdown, I think it was when they started to open up things that you could really tell were specific to the people on the public health board, golf courses, personal assistants, butlers, you know, and Arjumand and I were joking that the next thing to open would be tanning salons because it was so obviously created for people that are not from our community, you know, and it's these decisions that are just so blind and are so uninformed, and they really drive the pandemic for a longer period of time. And I think that if you can have that diversity on those tables, you can actually get down to business and you can get work done and you can get things under control a lot faster. You can also understand the ways that services impact your health and what needs to be opened and how things need to move forward to kind of bring an end to this for everyone. So, honestly, the lack of diversity in the public health board is a catastrophe, I think. And I hope that that's something that we learn to change. And I hope that that's something that not only the public health board, but every single board, hospital board, board of health, every single family health team, everybody needs increased diversity, and we'll see better outcomes and better health for all of us. And that will translate to more affordable health, to more affordable infrastructure. This will actually benefit all of us if we can actually just get it together.
Thanks so much. Yeah, Suzanne and I are on a group text that gets pretty live sometimes. So, Corey and Omishere, your thoughts?
I'm going to go first because I want Dr. Dryden to have the last word so that we leave here with whatever knowledge she's going to drop. So I'll be very brief. I agree with what you're saying. I guess some of the things that I would add to that is I'm thinking, as I mentioned before, coming from the healthcare system and a little bit, definitely it makes sense in public health as well, but really seeing a greater diversity and representation and of folks across at all levels of organizations. So I would say not just the board, I would say the board as well as the board also having on executive tables at all levels of organizations. The two things I would just say on that front in particular, one is I spent a number of years working in hospitals within acute care in the Greater Toronto area at a number of different hospitals. Loved working there, always felt a warm hug walking into these environments where I saw so many racialized folks, many people who look like, sounded like my family, ate similar foods, and it was always wonderful to kind of have that environment. As I started to kind of work in different areas in administration and things of that nature, it was a stark difference. So when we look at kind of the healthcare system, I can speak particularly to the Greater Toronto area. There's a lot of racialized folks who we're seeing in working in these different environments, and they work in very particular roles. And then you see like a stark difference. You just don't see that kind of thing represented in leadership. I would say at the system level as well, we need to see that shift also happening. The second piece I just want to speak to is also not having, even though I use the word representation, but it's not just having someone there. I don't want to work in an organization that has Black bodies sitting at places that uphold the ideals of white supremacy. I think that they need to come with a particular politic. I think they need to also come with that kind of radical activism that we discussed earlier as well, that is a part of the politic that they bring forward in the work, and that is ensuring that they are representing and speaking to the needs of community, and not just folks who are in bodies that are sitting at tables with folks who are common-minded or like-minded, reflecting the values of the same people who are there disenfranchising our communities. So I think that's critically important, because oftentimes we do see an ascension of Black and other racialized bodies who sit at tables and uphold the same structures that are holding us back. Lastly, I'm just hearkening. I'm hearing the voice of Camille Orridge in my head right now. That's thinking about that. She often speaks about the pipelines and really thinking about how do we put in process the structures that allow people to be able to have this kind of ascension in terms of opportunities and being positioned so that we don't have these kinds of issues where in this moment, if we were to snap our fingers and ask for a whole host of Black and Indigenous folks to be sitting at full executive tables, many of them have never been given the opportunities to even have the experience to be in a position to kind of step into these kinds of positions moving forward, because there was a ceiling and it hit earlier on, so they were never really positioned to do so, nor do they have the structures and support systems in place to ensure that they are successful in that. And that needs to start from a much earlier on age. It's actually to the detriment of our communities and another form of anti-Black and anti-Indigenous racism to turn to people and never support them in a situation. It's like taking someone who's looked at a pool and then saying, okay, I know you've always wanted to swim. We've never opened up the pool for you, but now we're taking you to the Olympics. Jump, right? So that doesn't make sense. So I think that really, how do we look at how we work upstream and earlier on to kind of ensure that we have a long-term kind of sustainable approach to ensuring that people will be successful and that we're looking in the future to put people in positions to be able to kind of dismantle the structure that we described earlier, that you described earlier in your question.
That's terrific. Thanks, Corey. Omishre.
It's such a great question. I'm not sure if I could identify a currently operating system that I think is effective, nor that should stay. I want to touch on a couple of things. Now my brain is running around. I do think we need to be cautious about our desire to sit at tables, especially since the table has already been structured. And there will be one Black person, one Indigenous person, one gay person who will most likely be a white gay person, and then women who will most likely be white women, right? So the Black person is often the Black person. They can't be the Black queer person on the table, right? They have these like siloed positions that they're supposed to occupy, and they're there for the work of the table, right? And I say this because in Nova Scotia, I was recently on the Nova Scotia Health Board with Stephen Augustine, Mi'kmaq elder. He was the first Indigenous person ever to sit on the board. I was the first Black person ever to sit on the board. I was appointed in March 2021, and then with the new elected government, the board was disbanded. And so, and in doing that, they replaced it with a 4-person administrative committee of 4 white people, and then began their kind of listening and learning tour of the province. So a couple of things. My concern around that is, many of the obvious, like we finally have this opportunity to, try and have some conversations there and kind of direct the piece, even though the table is fraught. It is not an easy place to sit and be. But the other piece is that, white people who are appointing these white decision makers who are appointing these these other decision makers don't bring within that that they need the qualification to have some kind of expertise in engaging anti-racism. And so they're like, oh, we want you to have expertise in finances, or we want you to have expertise in business. But they assume that finances aren't, their expertise in finances is situated through the matrix of white supremacy, or the finances or your expertise in business isn't situated in the matrices of white supremacy. They're just like, oh no, these are these colorblind things, and this is what we need. And then we'll have this conversation about equity, diversity, inclusion somewhere else. And so what happens is, because of the predominance of white decision makers who do not have expertise in Blackness, Black life, indigeneity, right? Who find it difficult to wrap their heads around, well, what does colonialism mean in 2021? Even though we can give them this data, are also the ones who are then making the decision whether or not something's racist or not, whether or not something is harmful or not, whether or not you are the appropriate person to be on the board, and whether or not you'll be a good member of that board. And if you're too crazy, as Suzanne said, too disruptive, then they will remove you from the board, or they'll dismantle the board and they will put something else in. And this is why, again, I want us to think about palliation in terms of, what is that line? What does that look like? But I also want us to think about what we can do in our communities to differently respond to or agitate with these systems. And so, yes, if we can have more of our voices on the table to shift and to move, that cannot stand in isolation from what we're also doing in our own communities. And in our own communities, it is to prepare and to provide for when the system will fail us. And I'm sorry if that's not like uplifting or, what I do hope is that, and you're right, like the Canadian Blood Services Board, predominantly white, and ineffective in dealing with issues of racial harassment, discrimination, or anti-Black homophobia. Public health boards, predominantly white, ineffective in dealing with these things. And so we, need to be effective with each other, train each other, work with each other, because we have expertise in our diverse communities, and then center what our communities need, and then take that, if we need to move, to disrupt the system, to create something new. I want to tweak the system. I want to create something new. I want to create something that centers our needs, our desires, our health, and our well-being.
That's not uplifting. I don't know what is. I am just going to state one more question that we won't have time to get to, but I think it's an important one given that we are a university hosting this seminar. And the question is, academics always think data solves problems because it's what they need for their professional survival. How would you recommend data be used to actually change a system rather than just describe its harms? So that's something that I want us all to leave with as one of our parting sort of next step questions as well, myself included. I'd like to take this opportunity to thank our three panelists. There are not enough words to describe how thankful I am for all three of you personally and professionally and for being with us here today. And I'm going to send it over to Dr. Nelson Lee, who is professor and interim director for the Institute for Pandemics at the Dalla School of Public Health, for some closing remarks. Dr. Lee.
Good evening, everyone. I'm Nelson Lee, the interim director of the Institute for Pandemics at the Dalla School of Public Health. Thank you for joining our event, Health, Equity, and Transformation Through Community Advocacy, and many thanks to our keynote speaker, Dr. Dryden, our panelists, Mr. Bernard and Dr. Shush, and our moderator, Professor Siddiqi, for an engaging conversation. The lecture and panel discussion has allowed some very useful insight on health equity as it relates to community advocacy, community engagement, and community level work. From targeting community-based and engaged perspectives to work with Canada's Black and Indigenous communities, the discussion emphasized the importance of tackling inequities in healthcare, particularly as it pertains to pandemics. And I've learned a lot this afternoon. So just let me leave you with a few broader questions to think about. In future large-scale epidemics or pandemics, how can we ensure equity in people's access to healthcare service, access to vaccines, access to accurate critical information? What public health policy changes are needed to minimize impacts to the marginalized and the vulnerable? What supports are needed to target the most affected and across the population strata during pandemic and in the recovery phase? What data do we need to quantify these issues and how? What are the roles of communities and civil society in addressing health inequity during health crises like pandemics? And these are actually some of the challenges that the Institute for Pandemics is prepared to address with its research and education efforts. So before I end, I just want to say a few housekeeping issues. Just to remind audience participants that the lecture will be posted to the School of Public Health YouTube page with closed captions following the event. Please check out the Institute for Pandemics website for future events and stay in touch. Follow the school on Twitter, Facebook, and Instagram, and hope to be with you again in future events. Thank you. Have a nice evening.